Okay, good morning. It's 7:30. Welcome to Urology Grand Rounds. This morning we have Dr. Nitu Kashyap, and she's the Associate Chief Medical Information Officer at Yale New Haven Health, where she's responsible for population health informatics and clinical decision support. She's the Assistant Clinical Professor in Internal Medicine at the Yale Primary Care Center and for the Yale Informatics Fellowship Program. And her research interests include development and delivery of guidelines-based clinical decision support. This morning, she's going to be discussing managing risk, malpractice, and the EHR.
So I'm going to share my screen for some CME information.
Okay, sure.
There we go. This is a CME series that we've just kicked off, and these are webinars usually at the noon time. Our inaugural one was just 2 days ago. We talk about, this is led by clinicians and physicians like yourselves who have found good practices and pearls, and we share those with each other in a live demo. So you're welcome to join. The next one is scheduled for June 26th. The email here is also available for any suggestions for future topics or things that you'd want us to cover. And all of that information will be posted on the physician portal that's listed here. And you can also get CMEs from the Yale CME site for those. And video recordings are also available for CME as well.
Okay.
Thank you. And good morning, everyone. It's a pleasure to be here. This is a topic very near and dear to my heart and also part of my day job for those who know me. I will start by keeping our vision, mission, and values right in front and center with a patient story. And this is a story from a while ago, and as I narrated, some of you might remember it. It's about a patient, TD, who walked into the ED in a metropolitan large hospital, where a nurse evaluated him, made some notes. A physician then evaluated the patient and discharged home. It's a very high-level summary. Turns out that that decision was not the right decision. The patient came back again to the ED, was admitted, and subsequently died from his condition. The question that was asked was, who or what was at fault here? And if you're thinking, I don't have enough information, that's quite right. There never is enough information in such cases. But of course, everyone would say the physician bears the responsibility of those treatment decisions. The question we ask is, were they supported adequately by people and processes in the system? Now, imagine the same scenario happen, except that the nurse then documents in an EHR. Just the thought that you had when I asked the original question, or who or what was at fault here, in your mind change in any way. I'll read you the statement that the organization released right after the incident to lay the groundwork for the rest of our conversation today. And I quote, "Protocols were followed by both the physician and the nurses. However, we have identified a flaw in the way the physician and nursing portions of our electronic health record interacted in this specific case," end quote. The story is from Texas Health Presbyterian, and the patient is Thomas Duncan, who's the only Ebola patient to die in the US back in 2014. So food for thought there. And hopefully you'll be able to better assess the situation towards the end of this conversation. The learning objectives for today are listed here. My hope is that by the end of this conversation, you will have some ideas of what to avoid when interacting with the EHR, and more importantly, what to do when interacting with the EHR. It is said that finding a lawyer in the US is really easy. In 2019, there were 1.35 million lawyers in the country and about 1.1 million physicians in the US. Thank goodness they're not all malpractice lawyers. And as they say, lawyers are always looking for holes, loopholes. that is. Here's an outline very briefly of what I will cover. Most of this stuff should sound familiar, so I'll go through it pretty fast. What exactly is the EHR in laypeople term? What constitutes malpractice? Some trends on EHR and malpractice claims, and some pros and cons of how the EHR has played vis-a-vis the malpractice scenario. And then arm you with some tools to walk away for a modern day clinical practice and shielding yourself from malpractice claims. So in simple terms, the EHR is a digital version of the paper chart with notable differences in the powers of information retrieval and the ability to share information across organizations and systems. Think imaging systems. How many times have we walked back to the image room today to view an image? Today we use our EHR as a documentation and billing tool and probably a few additional things. There are also other things that it does today, like communication, information retrieval, tracking of things like referrals and orders. This is where the untapped potential of the EHR is. Malpractice, or medical malpractice specifically, is unintentional negligence, and there are four things also referred as the 4Ds that need to be demonstrated when putting a medical malpractice lawsuit. There's a duty that's owed to the patient, a deviation or negligence can be demonstrated. There's a direct causality that can be determined, and specific damages have occurred. Some trends on EHR adoption, and you probably all have noticed and lived through it. In the last decade or so, there's been a rapid increase in EHR adoption. Hospitals were already there, but this is more for ambulatory practices as well. And in 2020, this number actually is more like 95%. This is the data from 2017. But in a comparable time frame, malpractice trends have actually trended down by substantial numbers. And these are claims that were paid. What has also been noted in parallel is that the large payouts have increased, so the overall dollars probably remain unchanged. So if you're wondering that my malpractice rates haven't changed, well, that's probably why. And in terms of data, this would be the most data heavy, number heavy slide. A lot of things that have been determined to be the causes of malpractice claims by a taxonomy that the lawyers have been using for some time. The big three still remain related directly to patient care, being diagnosis, treatment, and surgery. What is important to note is that EHR-related claims, where EHR was a direct cause, are about 1.2% of all medical malpractice claims. This data comes from our own malpractice carrier, MCIC. This is from 2016, and I saw Patrick on the call today. Patrick's been deeply involved in a project with MCIC, where Yale's part of a consortium to improve results and results tracking. So this is the list that MCIC provided to us as their assessment of our common risk domains. And I will cover the top three in some detail, and of course open to questions on those regard as it relates to the EHR. But first, there are some very general topics that are worth considering. If you see somebody familiar here, please let me know. I do not have any permission from the folks here to share these publicly, but they are taken from a public source. So a disclaimer here before you decide to share the slide deck outside of the organization, please. So eye contact with a patient is so important in making connection. This is not the first or the last time that you're hearing this. You can almost hear the patient saying, he didn't even look at me, his back was to me. He was working on his computer. In this image, however, you're seeing Dr. Kellner showing us how to do the right thing. He's looking directly at the patient, and he has a triangle between the physician, the patient, and the computer. This physical layout may not always be conducive, but if you remember the triangle and keeping the eye contact, that has been shown to be a great risk mitigator. And this is the one that our compliance department loves the most, and or loves to hate the most as enemy number one is copy paste. And I will refrain from using the word copy forward, which is sometimes used synonymously, but they are different in the EHR speak. So this is true copy paste. And in this example, I've hidden all the copy text and just highlighted what was added new by the provider in this note. That functionality is available to you in the EHR today, and you can toggle between those by using the hover section that I've highlighted here. So it makes the notes review quite easily, but you also remember that this is also therefore recorded in the EHR on what was the new data that was entered versus what's already been copy and pasted from other places. It is very easy to run a manuscript through a plagiarism software, and I'd suppose that any good lawyer would do that as a first thing. So keep those things in mind. Here I will also introduce an important concept called metadata, and you hear about that on the news channels these days when people talk about privacy, and Edward Snowden, I think, may have put it into our public jargon here. Metadata is really data about data, and that is the secret weapon that's built into electronic systems today, including the EHR. So in this case, the example here where when I hover over the text, I see who wrote the note and at what point in time. That is metadata that's recorded in an audit log somewhere, and it tells a story that recreates, so you don't have to document all such things going into every note, writing minute details. I did say you don't have to document everything, didn't I? And here I'm talking about documentation. Well, you do want to document quick responses so that the metadata can then be recorded, and you don't have to worry about details that are already captured as to who did what at what point in time. Whether you type, use macros, voice recognition, or virtual scribes, all of those go. And from now on and to the next few slides, I've tried to balance the burden of documentation against Z73.0. And if you're wondering what that is, it's ICD-10 for burnout. So in the next few slides, you should know that that's been in consideration, and it's top of the mind for a lot of us these days. Let's start with everyone's favorite, and this is a view of my in-basket. Remember, the ordering user is responsible for reviewing and interpretation of results, and how we get results is usually in our in-basket. This is also top of the list from NCIC, which I shared earlier. This is my in-basket, and it does not always look like this. It took me a while to get it into the pretty state that it looks right now, so I can display it proudly here. The ask for us is how to make this in-basket work for you. There are some items on this toolbar that I will cover, and hopefully you'll find some of those helpful, that not only lets you be more efficient, but also creates that safety check in result tracking that we're looking for, and of course, making our risk management teams very happy. Let's start by reducing clutter in the results folder as the first item to tackle. Why is this important? Because data has shown that for every 30 results in your in-basket, there's a chance that one critical result might be missed. And why do we get clutter? Well, of course, there's a lot of things coming to us in the in-basket. If we just look at results, the more patients we see, the busier we are, the more complicated our patients are, chances are that that folder reflects all of that. And one of the things that I often hear from colleagues is that, well, I keep things in my in-basket because I don't want to forget. Out of sight is out of mind. So I keep them hanging so that I can remember to follow up. There's one quick way to deal with that, and that's shown here in something we call postpone. And there's a speed button that's been made to postpone a particular item for 7 days. If that 7-day window doesn't work for you, there is another way to set up a different time frame and also tag this. You can also assign this follow-up to other members of the care team. But what it does really is it shows that message back into your in-basket. So if you have a lab result today and you're waiting for an imaging result, you can pop this message back in 7 days rather than keeping it hanging and making it fall to the bottom of your list. I know a lot of you have in-basket as delegated to other users, but if you haven't seen this before, this is an easy way to make sure that you have someone else attached to your in-basket who can actually take care of messages from patients or answer questions or take care of important tasks. In here is this is what I'm talking about. It's called the attach button. And in here, I can grant access. In this case, Diana is going to start seeing my in-basket when I grant her access. And the next time Diana logs in, she's going to see my in-basket under here in attached in-baskets. For your practice where you are seeing patients that come for specialty consultation from outside organizations, I hope you're all familiar with the Epic interoperability platform called Care Everywhere. This is where you can find results from outside organizations who also use Epic. And that information is indicated by the E sign right over here. And that crazy E tells you that this information came from outside. We have the ability to now see discrete lab results, imaging results, full notes even, and there are some great stories that our transplant department talks about on how they manage their patients who travel between locations. There's also a little window up at the top right of your Epic screen. If you're looking for some specific information, that search window is kind of like the Google for EHR, and it looks both internal and for outside information as well. Why is this important? Because missed results are important in malpractice cases, and they rank in our top 6 list from MCIC that we saw earlier as well. And if you ever take a vacation, do you ever sign out your inbox, much like you have your out of office for Outlook? There's a way to sign your inbox in the EHR out as well to a designated user, and this can be done months in advance. You set the date, put who's going to cover, and on that set date, when you're out of office, this person is going to start seeing your in-basket show up in that attached in-basket section. Also importantly, when people try to send you messages, they will see a notification that says this person has an out of office on, do you still want to send them a message? So that's helpful to know. Hopefully someday you will all be able to use this. Referrals or consults are an important part of a specialty practice, and it's important both on the incoming and outgoing side, inpatient and outpatient. Now, inpatient's less of a concern because the temporal lag is not as much as it is in ambulatory consults, and the chance that you will miss a consult are few and far in between. There are a couple important things in referrals to consider. One is that the clinical reason for referral needs to be documented by the requesting provider and also by the consulting provider when they're documenting their consult. And we need to be able to close the referring group. Most of us know that because that's required for billing as well. And if you ever have a practice of pre-screening all your referral requests to make sure that they're booked in a timely manner, there's a referrals tab in chart review and Epic. The screenshot shows that, but this is helpful in making sure that the appointment for the patient is set up in a timely manner. Now, referrals are interesting. So far, we've talked about things that are physician and provider centric, but healthcare being a team sport, this is where most of the work can actually happen on your quote unquote referral desk side, meaning your practice staff has some do's and don'ts that they can follow to ensure whatever we just talked about. So in order for you to be able to close the loop on some of these things, it's very important to have your practice staff do certain things in a particular way as well. So this statement was what showed up when I searched Google with the words malpractice and medication. And it links out to a lawyer's webpage. And it must be a busy lawyer because the website also provided with a checklist before I could actually schedule an appointment with the firm. And if you wonder what the checklist was, it actually was the 4 Ds of malpractice that we talked about earlier. It's eliciting whether harm happened, whether there was negligence or deviation from standard practice, and things like that. Inpatient claims that are medication related are mostly around wrong dose, wrong patient, and often are system errors. Most medication claims are from poor management of meds, wrong dose, continuing a medication despite side effects, and etc. Medication renewal is an important opportunity to cross-check a few things, like have you seen the patient recently? Is this still the right dose? Are there any side effects? If you have someone in your practice that's actually doing this by med renewal protocol, they're probably doing the chart search and finding all this information. What you see on the screen is decision support that's built in within the renewal request that comes into Epic. And that decision support is based on medication class. We work with our pharmacists to come up with this decision support, and it surfaces common safety checks and gives you a visual cue when you're going to renew medications. There are a few that are relevant to your practice that you might see these occasionally. We know healthcare is a team sport, and this is a screenshot of the patient's care team. If you're not familiar with it, it is a place in the chart where physicians and providers who are part of this patient's care are listed. And why is that important? Because it helps in not only tracking who the owner of a particular problem for this patient is, who's the team champion there, also helps us in reporting. Think about it as when you're trying to maintain continuity of care for future schedules, and then also a place where ED looks to see who to call if your patient is in the ED. What I show here is this can be leveraged in an additional way. If you have a high-risk patient that you're trying to watch very carefully, you can set some settings here to to be notified of each admission. And working with your practice manager recently and with Jamie Cavallo, we found that someone in registration was actually setting all of your care teams to be notified of all admissions. So if you were seeing a ton of admission notifications coming to your in-basket, that was the reason, and we've since been able to roll that back for you. Patient communication and staying connected with your patient is key in maintaining good physician-patient relationship. Again, another one where practice staff can be the first line of defense for incoming messages, but my chart and patient portal messages are an important way of keeping connected asynchronously rather than trying to play phone tag. And in here, the screenshot displays a result note that was sent to the patient, and it appears at the top of the results for the patient as a comment from the doctor's office. Now, it is said that lawyers love to see fractured communication. If your documentation is split between systems like phone, email, it becomes harder to track, and those breadcrumbs get broken. Again, those things are conducive to our workflows, but as long as somebody somewhere is summarizing them in a quick note inside of the EMR, then we have a fighting chance of demonstrating that care happened outside of the EHR, but it was summarized at this point in time. So keeping those things in mind, wherever possible, use a telephone encounter to document such things. And yes, we kill ourselves with kindness by thank yous back and forth every time you answer, and that is somewhat of a messaging etiquette that we can we need to work into our lives. One special note on texting: your cell phone carrier-based texting is not HIPAA compliant. Secure texting platforms like Mobile Heartbeat, which I know a lot of you use, is the acceptable solution there. Who loves to see alerts in the EMR? I will say you heard that this is one of my interests in academic settings as well as in a clinical setting, is clinical decision support. What we've been able to do in the organization in the last 3 years is decrease the amount of alerts that fire by about 33%. Despite the fact that the number of alerts have continued to grow, we are now at par or slightly below other of our peers in terms of alert volume. People, and we've shared that with at public forums and with conferences as well. Now, how does alerts relate to risk management and medical malpractice? Is you can imagine when you cancel or ignore an alert, it's documented in the chart, and it provides fodder for anyone to pick that up as an act of negligence. What I ask is to give yourselves 5 to 8 seconds of dwell time before you take any action on alerts. Yes, it's time, but it's well spent. And if this is an alert that you're seeing for the first time, those 5 to 8 seconds will help you in doing the right thing and be able to hopefully save some clicks later on. That also ties in very closely with our HRO behavior in the organization. This is, well, you're all into continuing education skills, and that's why I see the participation in this CME activity. Physician skills and continuing education are valued by clinicians and have long been, whether it was learning how to use a stethoscope or a bedside ultrasound or an advanced imaging interpretation, or in this case, an EHR. think of those things as just another tool that you need to understand and continue to keep up with. There are CME courses available for EHR and optimizations as well. I have some information I'm happy to share as well. Several of these sessions are led by our informatics colleagues, and hope to see you there soon. I will summarize here this whirlwind conversation in that EHR adoption has correlated with a decrease in paid malpractice claims. It may just be an artifact, but the trends are clearly there. EHR-related claims form a small percentage of malpractice claims as a direct contributor. Now, EHR, however, can offer several opportunities in key areas to build our defenses. And the areas we covered are listed here. They pertain to documentation, leveraging the data and metadata that's stored in the EHR, decreasing transcription errors, decision support, tracking and information retrieval. What we didn't touch here, but it's fairly obvious, is timely access to patient data. For those of us who've used EHR to be logged from home for televisits, or when we're on call, or use the mobile application for Epic on our phones, that speaks volumes right there. And also, it offers a way to clearly communicate between different entities, with the caveat that we have to make that work for us by making sure the communications are succinct and clear. So keep that in the back of your mind. And with that, I welcome any comments, thoughts, and discussions. My email is right here if you'd like to reach out to me. And I'll back to you.
Thank you, Dr. Kashyap. I do have a message in the chat from Dr. Ricky, which states, I find it challenging trying to figure out what Care Everywhere documentation contains actual note results versus just visit type data. So this requires looking through every single encounter entry.
Mm-hmm. So 2 ways, and I'm assuming you're already familiar with the Care Everywhere tab. The search window allows you to, if there's a particular thing that you're looking for, you can use that search window to find it, and the window that pops up with the search results actually tells you whether this is coming from an outside entity, and there's a direct link to take you to that information. What we've also done with Care Everywhere in the last year is that information from Care Everywhere is now visible in not just from within that tab, but also within the relevant sections in the EHR itself. For example, the outside encounters are now blended in with your encounters from within the health system, and they will all show with that crazy E icon. Labs from outside similarly are visible from the Labs tab, and similarly imaging as well. So hopefully that makes it a little bit easier to find information that's coming from outside. Did that get to your question?
Yeah, can you hear me?
Yes.
Oh, yeah, thank you. It's just, I feel like sometimes I'm like just combing through notes, and sometimes I open it up and it's just like sort of admin visit type data about what type of visit it is. So, yeah, thank you.
Yeah, and yeah, no, I totally understand. And the challenge we have with any type of interoperability tool is that there are limiting settings that we have on our end to work with. We're kind of dependent on the sending organization. So if they're sending information that's duplicative, then that's what it is. We have tried to put some filters on our end to kind of recognize and decrease that clutter, but oftentimes it is dictated by the sending organization. if you have patients that
Yeah.
you share with Hartford, UConn, which are also now in Epic, we've been working very closely with them to sort of mitigate some of that clutter that you're describing.
Thank you.
Dr. Kashyap, I also have a question from Dr. Singh, which states, can you comment on how plaintiff lawyers have used deep dive audits in EMR to their advantage in getting doctors in trouble? By audits, I mean where they look at timing of clicks and viewing of things. Can you give a few examples?
It is a deep question. I will try my best. So in terms of leveraging the data, and this is what I was describing as metadata, it can be used in both ways to paint a story. And lawyers on both sides, I think, would try to paint that story to their advantage. It's not just the plaintiff's lawyer. We've also seen cases where the documentation in the EHR, as well as those clicks and how long you dwelled on a screen, were requested by our own legal team in support of the clinician there. So either party can use it. It is also not part of standard release. I believe they do have to ask for those things. So your legal team's expertise is important.
Dr. Kashyap, this is Dan Kellner. I have a question about the patient is referred to us, say by a primary care doctor. I'll just give an example of something like an elevated PSA, and they send the data to us, so it's entered into our electronic record, and we look at the data. But say the patient never actually makes an appointment, or you never actually engage the patient and establish a relationship. Is there any liability that we have because we've seen this data and it's in the record?
Are you talking in the context of things like e-consults, or this was a referral that was actually not booked and was lost to follow-up?
Well, a referral, but it never came to fruition, where the patient never ended up making an appointment, was not able to be contacted.
Yeah, there is some liability, which is why I said that the practice processes on referrals need to be tight, because we have to be able to demonstrate good faith effort was made, that there was an effort to contact the patient in a reasonable amount of time. And this is where I think the processes are important. There are some best practices that we created a few years ago, and happy to share that. But there is, if this was a referral made to the practice, whether it was a named provider or just to the practice, we do carry some of that responsibility to make sure the appointment's actually booked and actually happens.
Thank you.
Any other thoughts or questions?
Dr. Kashyap, yes. So I have one from Richard Licitano, which states, thank you, Nitu, for your excellent presentation. Can you speak to strategies we can apply to reduce unnecessary in-basket messages?
Rich, thank you for the question. That's been my favorite topic for the last, I think, several months. What we've tried to actually do is look systematically at in-basket folders and address them in a systematic way. And we've been calling this plan the in-basket diet plan. The idea being to address it in three ways. One is, if this is like a snack, nobody really wants it. Messages like, oh, your medication was canceled at the pharmacy. You don't need to know this. It should just go to file. We've been removing those messages type. If someone were to go into a note of mine and writes an addendum, I don't really need to know about that. So those kind of messages we've taken away. The others were where we were sending a lot of messages, and this is an example more from my world as a PCP, where we send a notification when a patient of mine arrives at the ED, then we send another notification saying Johnny's being admitted, and then we send the admission HNP. So we've been able to truncate some of those notifications and collapse them into one notification at an appropriate time. The last one that we've been working on is addressing in-basket messages type by looking at upstream workflows, which means diving into a lot of practice operations and best practices on how practices deal with workflows, on what goes in as an in-basket message often is dictated by the fact that something upstream happened. So if I'm getting a notification that a lab was, for example, canceled and reordered, it is because something upstream in the lab didn't match up. And what are some of the things we can do? We recently presented at the informatics conference, and we've been able to decrease our in-basket time in basket by about 12 minutes per provider, which may not sound like a lot, but if you're spending 40, 50 minutes just navigating the in-basket, it all adds up. Rich, hopefully I got to the crux of where you were going with this. Happy to answer any follow-ups.
Yes, thank you, Nitu. That was great.
Okay, and from Dr. Foster, we have, can you comment on whether or not patient access to physician documentation, i.e. office notes, is a good thing, and if it can have impacts on liability? For example, patient may dispute what was recorded, documented by the physician.
Mm-hmm. You're referring to open notes, if I'm not mistaken. So we do have, we're one of few organizations who are leading the charge on sharing notes with patients. It is actually not a very new idea. Specialists in particular have done it for a very long time, where I remember as a trainee, my attending was dictating the note in front of the patient. What's been found is there are a few patients who will call back the practice or the medical records for some correction. What we found in our own experience is those are minor, and maybe the transcriptionist didn't get the spelling of their name. That was one particular one that comes up. Or small parts of their chart saying, well, I quit smoking, such and such time ago. It still says that I'm a smoker. Can you please update my chart? Most of the time, it has not been a concern for patients. In fact, there is a sense of trust and connectedness with the provider. There's an openness. In our own experience, while we've had open notes shared across the organization in multiple pockets, people haven't gone and looked at those notes. But the sense of, there's openness and my physician isn't hiding anything prevails. So it's that feeling that overrides the concerns that people have had that it will cause more angst from the patients about wanting to correct the medical record. Dr. Foster, hopefully I got to the crux of your question.
You did, thanks.
Okay. So I'm going to share my screen for some CME information.
Okay, sure.
There we go. This is a CME series that we've just kicked off, and these are webinars usually at the noon time. Our inaugural one was just 2 days ago. We talk about, this is led by clinicians and physicians like yourselves who have found good practices and pearls, and we share those with each other in a live demo. So you're welcome to join. The next one is scheduled for June 26th. The email here is also available for any suggestions for future topics or things that you'd want us to cover. And all of that information will be posted on the physician portal that's listed here. And you can also get CMEs from the Yale CME site for those. And video recordings are also available for CME as well.